Hi everybody, Dr. Mike here. In this video, we're going through one of my favorite topics, which is an overview of the peripheral nervous system. Now, to start off, we need to understand what the peripheral nervous system is. And basically, it's everything that's not the brain, brainstem, and spinal cord, because we know that this is the central nervous system. The peripheral nervous system are all the nerves that shoot out and away and come back in towards the brain, brainstem, and spinal cord. And so that means you can basically break up these nerves into those of the brain and brainstem, which we term the cranial nerves, and those of the spinal cord, which we term the spinal nerves, which I'll draw up shortly. But there's two functional subdivisions of the peripheral nervous system. First of which is that of the autonomic nervous system. Autonomic sounds like automatic, and that's exactly what it is. This is the division of the peripheral nervous system that controls all involuntary things. This may be sensory information coming in from our organs or viscera. It may be information coming out towards our organs and viscera to tell things like our heart to contract. It may tell things like our smooth muscle that line our gastrointestinal tract, or our blood vessels, or our genitourinary tract to constrict or dilate, or it may tell some glands to release hormones or chemicals. All these things that we don't consciously control, that's the autonomic division of the peripheral nervous system. The somatic division, soma, somatic, body, these are all the things we do consciously control. So it can bring sensory input in from our periphery, but also send a motor output to things that allow us to consciously move. Basically, our skeletal muscle attached to bone. So things that allow for me to walk, talk, sing, dance, move, all those types of things, somatic division. But the take-home message is, regardless of autonomic or somatic, these particular nerves either shoot out and away or come back into the brain, brainstem, and spinal cord. So let's have a look at those. Let's begin with the nerves of the brain and brainstem called the cranial nerves. They are paired, and there's 12 of them. They're paired because they come out and go back in to either side of the brain and brainstem. And you can see they're written up in Roman numerals because we like to make things harder for you. Each of them have a particular name. Some of them are hard to remember. So I like to use a mnemonic, which is a device, a memory device to help you remember the names. This is how I do it. I remember O, 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 to touch and feel very good velvet heaven. That's my mnemonic. And you can see the first letter of each of those words is going to be the first letter of each cranial nerve. O, to touch and feel very good velvet heaven. So what are the cranial nerves? First of which is olfactory, then optic, then oculomotor, then trochlear, then trigeminal, then abducens, then facial, then a big one, vestibulocochlear, which is just as hard to say and spell at the same time, glossopharyngeal, pharyngeal, vagus, accessory, and hypoglossal. So these are the 12 cranial nerves you need to remember. Now, the other thing is, some of them are sensory, so they bring information in about the environment. Some are motor, they send information out, and some are both. How do you remember what's what? Another mnemonic. So, some say marry, money, but my brother says big brains matter most. And you can see it's either S for sensory, M for motor, B for both. Now let's have a look at the function of each of these cranial nerves. So olfactory, sense of smell, you can see it's sensory. Optic, sensory. Vision, oculomotor, motor, movement of eye for ocular, but there's actually 3 nerves here, oculomotor, trochlear, and abducens. These 3 motor, allow for us to move our eyes. Trigeminal is both. So this gives us our sensation of the face and also the ability to move the jaw. We've got facial, which is both. So this is movement of the face now, not sensation, movement of the face and sensation or taste of one aspect of the tongue. Vestibulocochlear, this is going to be balance, for example, and it's also going to be sound. Glossopharyngeal is going to be, glosso means tongue, pharyngeal means throat. So this is going to be swallowing, but also taste. Vagus, which is going to be predominantly what we're going to find. Vagus is number 10, as you can see here. Unfortunately, they don't align properly. Vagus being number 10 is sensory and motor, and this is important because it's the only cranial nerve which goes beyond the head and neck, and it actually innervates the heart, the lungs, the digestive tract, the urinary tract, and so forth. Accessory, shoulders, shrugging. Hypoglossal, under the tongue, motor movement of the tongue. And this is how you summarize the 12 pairs of cranial nerves. If we have a look at the spinal nerves, firstly, the spinal cord can be broken up into various divisions. So you've got the cervical or cervical. You've got the thoracic. You've got the lumbar. You've got the sacral. And you've got the coccygeal. And what you're going to find is there's a various number of nerves that shoot out and away or come back in at these particular regions. So for example, cervical has 8 pairs. Thoracic has 12 pairs. Lumbar, 5 pairs. Sacral, 5 pairs. Coccygeal, 1. And the way I like to remember this is the time that elderly people tend to like to eat their food at 8 a.m., at 12 p.m., and at 5 p.m. And then it's 5 and 1. And these are the spinal nerves. Now, interestingly, when we look at the autonomic nervous system, you can subdivide that, obviously making things a little bit more difficult for us. But if we were to look at the autonomic nervous system, there's 2 particular subdivisions. That of the sympathetic and that of the parasympathetic. So sympathetic, we also term our fight and flight. Fight and flight. This is what gets activated in times of stress. Parasympathetic is rest and digest. This gets activated in times of relaxation. They're the flip side of each other, for example, and their various nerves or fibers that innervate these structures to allow for us to stay alive in times of stress or stay alive in times of relaxation actually branch off either the cranial nerves or that of the spinal nerves. So let's have a look. Firstly, let's have a look at parasympathetic, because parasympathetic, their fibers come out of the craniosacral regions. So the parasympathetic fibers are craniosacral, which means they come out of the cranial nerves and the sacral nerves. So let's have a look. What cranial nerves are parasympathetic? Well, they're going to be cranial nerve 3, cranial nerve 7, cranial nerve 9, and cranial nerve 10. What these cranial nerves do is they innervate structures that allow for us to promote resting and digesting. For example, oculomotor. Oculomotor, being motor, allows for our pupils to contract and relax. And in times of relaxation, what happens is our pupils, they start to constrict. When we have a look at number 7, which is facial. Facial, I said, allows for us to move our face and have taste, but it also innervates our salivary glands, which we need for resting and digesting. Number 9 is going to be glossopharyngeal. This is going to be swallowing, for example, but also salivation of other glands. When we look at number 10, which is vagus, this structure innervates things like our heart to tell it to slow down. We're relaxing. Our airways constricts a little bit and tells our digestive system to activate and release those digestive enzymes and hormones and so forth to promote relaxation and digestion. They're the cranial aspects of the parasympathetic nervous system, and the sacral aspects, which are going to be shooting out, are going to be innervating everything basically from the certain part of our digestive system, so our colon, to our urinary tract and renal tract. So I would say parts of our GIT, gastrointestinal tract, and our genitourinary tract. And that's our parasympathetic division. What about sympathetic division? Well, sympathetic division isn't craniosacral, it's thoracolumbar. So the neurons that are shooting out and away from the spinal cord or coming back in for the sympathetic are thoracic and lumbar. thoracolumbar. And they come out of the thoracic and then the first two lumbar. And again, where are they going? Well, they're going to go to similar structures. They're going to go to our pupils, but this time tell our pupils to dilate. They're going to go to our heart, but tell it to speed up. Going to go to our airways, tell it to relax and open up, get more air in. Why all these things? Because I want you to think about it. Anytime you are fearful or in a stressful situation, what happens to your body? Look into the mirror. Pupils dilate. You become pale. Why? Because the blood vessels constrict in your periphery to give blood to all your muscles because you might need to fight or run away. It also goes to other structures. For example, it stops the digestive system because that's not part of sympathetic, that's parasympathetic. All right. So it opens up the airways, getting more air in, more oxygen to be delivered to the body. The heart speeds up, delivers more blood around the body to fight or run away. So that's how you should think about these divisions of sympathetic, parasympathetic. But simply put, sympathetic, thoracic, and lumbar, all the organs that get activated there to keep you alive in times of stress. Parasympathetic, craniosacral. The cranial nerves are 3, 7, 9, and 10, and sacral nerves, and they get activated to promote resting and digesting. And this is a quick run through of the peripheral nervous system. Hi everyone. So today, which is the beginning, well, halfway through, I should say, of week 8. All right. So we've got 12 weeks of this semester. We're already in week 8. And it's our final week of the nervous system. So this is the peripheral nervous system tutorial. Now, a couple of things for week 8. One, you've now submitted your assignment. So your assignment was due originally on Monday, 5 p.m. We extended it by 24 hours, so it's due yesterday, 5 p.m. So hopefully everyone submitted that. Now the question may be, when will you receive your results for your exam, your assignment? And the answer to that is probably around about 3 weeks. And the reason why is because students apply for extensions and deferrals because of different reasons. And so we can provide them up to 21 odd days of extensions, depending on the issue. So we can't actually give students any results on their assignments until all students have submitted it. So around about 3 weeks, expect to get your results for that assignment. So thank you for doing that. Now we can start focusing more on some content. We can start looking at the end of trimester exam and how best to prepare for that. Second point is that this week, being week 8, we have an online quiz. Now, I've told you, but all your online quizzes have been extended now for 2 weeks. So the online quiz may open this week, but it's not due this Friday, it's due next Friday. And this online quiz will assess you on 3 weeks worth of content. It's basically all the nervous system. So this week's quiz and next week's quiz, I suppose, which is the same quiz, is going to assess you on fundamentals of the nervous system, central nervous system, and this week's topic, which is the peripheral nervous system. Now, do you have any questions at the moment? If you have any questions, please let me know, and I'll be able to answer those questions while we do some of this housekeeping work. Okay, this week being peripheral nervous system. I know you've probably been spending a lot of the start of this week on your assignment, but hopefully you've had the time to watch the lecture or at least engage with some of the YouTube videos that address this week's content, which is peripheral nervous system. We spoke last week about central nervous system being the brain, brainstem, and spinal cord. And we spoke about how briefly there's nerves that shoot out and away from the brain and brainstem and come back in, and nerves that shoot out and away from the spinal cord and come back in as well. The nerves that come out and away from the brain and brainstem and back in are called cranial nerves, because you know cranial is referring to head. And the nerves that come out and away and back into the spinal cord are called the spinal nerves. Now we're going to be focusing on these in this tutorial. And what I'm going to do is try and put as much clinical relevance in. I don't want this tube to just be a didactic like usual, me talking, just another lecture, because you get enough of that with your face-to-face, with your originally face-to-face lecture and your YouTube videos. So I thought we'll try and make this a little bit more engaging for you. All right. So when we look at the peripheral nervous system, like I said, what I want to draw up is the brain. Again, similar to how we drew it up last week, we'll do the brain. We're going to do the brain stem and we're going to do the spinal cord. And we'll put that cerebellum in. So remember, this is going to be this is the anterior, this is the front, this is the posterior. This is the back, right? So you got your cerebrum, you got your cerebellum, you got your midbrain, your pons, your medulla. None of this should be new. This is recapping last week. And we've got our spinal cord. All right, now, when we look at the brain and brain stem, there's going to be 12 pairs of nerves. So when I say pairs, it's going to be one shooting out either side. There's 12 of them from the brain all the way down to the bottom of the brain stem called the medulla. So there's going to be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Now these nerves, like I said earlier, are called the cranial nerves. And that's what we're going to start this week's tutorial on, is these cranial nerves. And then we look at the spinal cord, there's 31 pairs. And we briefly spoke about that last week. With these 31 pairs, you got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 2, 3, 4, 5, 6, 7, 8, 9, 30, 31. How are they divided? Well, we break them up into the cervical, thoracic, lumbar, sacral, and coccygeal, remember? So cervical, thoracic, lumbar, sacral, coccygeal. And last week I said to you that there were going to be, or there are, 8 pairs of cervical nerves, 12 pairs of thoracic, 5 pairs of lumbar, 5 pairs of sacral, 1 coccygeal. Add that up, 31 pairs. All right. We're going to focus on the cranial nerves now. So what I'm going to do is we're going to draw up, well, we're going to write up a couple of things and then I'll show you some important points. Again, any questions at all about content, please just write them in the box and I'll be able to answer you. All right, so when we look at the cranial nerves, now this is the thing, right? I will assess you on cranial nerves. You need to understand cranial nerves as a practicing medico. Now there's 12 pairs and they've all got names. Sometimes it's difficult to remember the names, but if we use a mnemonic, it helps. So a mnemonic is just using other words to help you remember more difficult words. All right. So for example, I want you to write this down for me. Write down O, 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 to touch and feel very good velvet heaven. Now, if you've watched a YouTube video, this is recapping. If you've watched a lecture, this is recapping, but we need to start here so that we can move to the more complex things and bring things together. O, 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 to touch and feel very good velvet heaven. This is what we're going to start with. If you count, there's 1, 2, actually, let's put numbers next to this. Now, when we do cranial nerves, we use Roman numerals. Why? I don't know. This is medicine does some crazy stuff sometimes. So you just need to be able to put the Roman numerals next to it from 1 to 12. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. All right. So now we've got the 12 there. You're going to wipe the letter out, the word out, and just leave the first letter. Now, the first letter is the first letter of each pair of cranial nerve. Because the first cranial nerve is going to begin with an O, and the second one O, third one O, and so forth. So let's have a look. The first cranial nerve is olfactory. Second cranial nerve is optic. Third cranial nerve is oculomotor. Fourth cranial nerve is trochlear. Fifth cranial nerve is trigeminal. Then it's abducens. Then facial. Then, horrible name this one, vestibulo. Cochlear. Then it's glossopharyngeal. Then it's vagus. then it's accessory, then it's hypoglossal. All right. Can everyone read that? That's the first question. So please comment for me. Can you read the words that I've written there? Because we're going to go through them now. We're going to go through what they mean. Olfactory. So if somebody has a sense of olfaction, they have a sense of smell. So that gives you an indication what the first cranial nerve does for us. Optic. Optic means vision. That again gives you wonderful. You can see. Well, optic. Your optic nerve is working well because you can read these words. Good job. Next one, oculomotor. It also has ocu in there, which means vision, but motor. So maybe it's moving the eyes. Trochlear means pulley. Maybe it's pulling the eyes somewhere. Trigeminal means 3 branches. Abducens means to abduct, take away. Maybe this is moving the eyes away from the midline of the body. Facial, face. Vestibulocochlear, there's a word. Vestibulo means balance. Cochlear is referring to inner ear. Glossopharyngeal. Glosso means tongue. Pharyngeal means back of the throat. So this has something to do with the tongue and the back of the throat. Vagus. Vagus is Latin for wanderer. This is the wandering nerve because it's the only cranial nerve. So think about this, right? All these nerves come out of either the head or neck. I'll say it again. All these cranial nerves only leave the brain or brainstem. That's it. They don't come out of the spinal cord. They don't come out anywhere else or come back in anywhere else. Just brain and brainstem. Now, what does that mean? It means that these nerves, all of these nerves, only innervate structures of the head and neck. That's it, except one. The vagus nerve means wandering nerve. This nerve actually travels beyond the head and neck and innervates the heart, innervates the lungs, innervates the digestive tract. It's a really important nerve, the vagus nerve, but we'll talk about it again in today's tutorial. Accessory. The accessory nerve is actually a nerve that innervates the trapezius, so parts of the neck and shoulders. And hypoglossal. Hypo means under. Glossal means tongue, has to do with something under the tongue. Now, I haven't told you the specific functions of these yet. I've just been breaking the words up to make it a little bit easier for you. Next thing we need to do is determine whether they're sensory or motor. Because remember, your body will either pick up changes in the environment, and that's called sensation, or it's going to send out. So this is all coming in, right? All sensation comes in. We spoke about last week through the dorsal nerve root, right, of the spinal cord. And motor is output. This is to move things. This always comes out the ventral nerve root. So nerves are either having a sensory function, so they pick up information and bring it in, or they've got a motor function where they send information out. Some nerves do both. So let's have a look here. Here is another mnemonic for you to remember. Now, what have you got here? Is chapter 16 sensors on the quiz test? No, I'm not going to test you on sensors, but I will test you on cranial nerves. All right, write this one down for me. Some say marry money, but my brother says big brains matter most. So again, 12 words that I've put next to each of these. I'll read it again for you. Maybe if you can't see it because green's pretty horrible. Some say marry money, but my brother says big brains matter most. Now this is another mnemonic, and it's only made up of S, M, and B. So again, I want you to wipe off the rest of the word and just leave the first letter. And this is going, now this mnemonic is telling us whether the cranial nerve that we're looking at has a sensory function, a motor function, or both. Clinical referencing really helps me. If you can that, I'll definitely make this clinically relevant for you. I promise you that, because right now you're probably looking at this going, oh God, we're going to remember a whole bunch of terms that I have no idea why. So we've now wiped off the rest of the word. S stands for sensory. Actually, I don't need to write it down. You can remember this. S, actually, I'll write it for the first couple. S stands for sensory. M stands for motor. B stands for both sensory and motor. So what this now means is if we go through, the olfactory cranial nerve is there for sensation. So bringing information in. Optic, sensation. Oculomotor, sending motor, it's in the name, so that's not a surprise. Sends a signal out for things to move. Trochlear, motor. Trigeminal, both sensory and motor. Abducens, motor. Facial, both sensory and motor. Vestibulocochlear, just sensory. Glossopharyngeal, both sensory and motor. Vagus, both sensory and motor. Accessory motor and hypoglossal motor. All right, now let's talk about what they do. So first thing is this. Olfactory, I told you, if you have a sense of olfaction, you get a sense of smell. So the sensation for olfaction is smell. For optic, it's sensory. This is vision. So you know when you go in and you do that test where you stand there, you got all those letters on the chart, and they start really big and they move to being really small, and you cover one eye to the other eye. This, in part, is testing the optic nerve. Oculomotor, this is motor. This is eye movement. Oculo meaning eye, motor meaning movement. Eye movement. So let's write eye movement. Trochlear is also eye movement. And I'll explain why there's a couple here. Trigeminal is both. So the sensory, that means there's both sensory function and motor function. Sensory function, right, of trigeminal. Now, because it's called trigeminal, it's 3 branches. These branches are like this, okay? Now, these branches go up towards the eye region, towards the top of the jaw, and towards the bottom of the jaw. That's these 3 branches. And the sensory function of these 3 branches is to give sensation of your face. So if you had a patient and you had a cotton bud that was wet, told them to close their eyes and you rub it across the top here, you rub it across here, and rub it across here, you were testing the 3 sensory branches of the trigeminal nerve. Sometimes people can have issues with just one. So they don't feel anything here, but they still feel things here. So there's a trigeminal branch issue, right? One of the 3 branches. So sensory is simply sensation of the face for trigeminal. The motor for the trigeminal innervates the jaw for movement. So being able to open and close the jaw, that's the function of the trigeminal nerve. That's the motor aspect. Abducens. Abducens is also eye movement. So let's stop here for 1 sec. We've got 3 involved in eye movement, right? So for eye movement, we've got oculomotor, trochlear, and abducens. And they all do different things. Now, it's quite complex in regards to the types of movement you have, but they all work together anyway, right? And so I'm going to talk to you about how you can test all these things in a second. But when you look up, down, left, right, and even track objects with your eye, you are testing all 3 of these cranial nerves: oculomotor, trochlear, and abducens. Now on to facial, and facial is both sensory and motor. If we look at the sensory component, the sensory component of the facial nerve is for taste. And it's actually, this is a strange thing, right? Because of embryology, the tongue, obviously giving us our sense of taste, there's 2 nerves that give us our sense of taste, and they innervate different parts of the tongue, which means taste for the front of the tongue comes from one nerve, and taste from the back of the tongue comes from another nerve. So when it comes to the facial nerve, it gives us taste for the front 2/3. So let's write this down. I might extend this out so I can write it a little bit bigger for facial. So for facial, the sensory component is taste, 2/3 anterior, right? So the 2/3 front of the tongue is taste from the facial. What about motor? What does the motor part of the facial nerve do? Well, it allows for our entire face to move. Smiling, crinkling the forehead, moving our face and our cheeks. This is the facial nerve. So face movement. Now, you may be thinking, wait a minute, what about trigeminal or something to do with face? Trigeminal is sensation of the face, yet motor movement of the face is another nerve. So to feel the face, trigeminal, to move the face, facial, right? So it's complex. Vestibulocochlear is all sensory, and it's basically hearing and balance. They're both ability of sensation, bringing this sensation in. So hearing, now, if you have any questions about any of these, please just write it up. You can say, Mike, stop. I just want a bit more information on one of these cranial nerves. That's fine. So when we look at glossopharyngeal, is both sensory and motor. The sensory component of glossopharyngeal is the posterior 1/3 of taste. So it's taste, but it's 1/3 posterior of the tongue. The glossopharyngeal, also for motor, allows for us to salivate. So our salivary glands in our mouth. Now there's another nerve that allows for us to salivate, which I didn't talk about, which is the facial nerve, because if you can move your face, you can also stimulate it to salivate. So both facial nerve and glossopharyngeal allow for salivation. Now a couple of questions. If you damage the nerves with motor and sensory together, will you destroy both of these functions? Hope that makes sense. No, that's a really good question. So yes and no, because remember last week we spoke very briefly about ascending sensory pathways and descending motor pathways. Now for sensation, it's a 3-neuron chain, remember? I said for sensation, you've got one neuron coming in, synapsing with another neuron, which usually crosses over, but that's okay. We'll just do it like this. And then a third neuron that goes up like that, right? So this is the periphery, this is up in the brain. That's sensation. So this is all going up. And I said for motor, it begins up here. Like that. So this is the brain, this is descending. This is the brain, and this is the muscle that wants it to move. All right, so that means for these neurons, the sensory components are 3, the motor components are 2. You can damage an upper motor neuron or a lower motor neuron, and it's different. So it really depends. So you can damage the lower motor neuron of this nerve, and it doesn't affect the sensory function. You can affect the upper motor neuron, doesn't damage the sensory function. Depends whereabouts you're damaging the nerve. Does that make sense? I hope that makes sense. So it's all about and I'm going to talk about this because I'm going to give you an example of a stroke soon. And I'm going to ask you about which of these are going to be damaged when we have a particular stroke in a particular area. So Cody, please let me know if this makes sense. I'll go into more details shortly. It's a good question though, very good question. So glossopharyngeal, I said, was posterior 1/3 taste of the tongue, and motor was salivation. But it's also one other thing for glossopharyngeal, it's swallowing. That's the motor. So salivation and swallowing. For because tongue, pharyngeal, pharynx, back of the throat. So it plays a role in swallowing. Makes sense, thank you. So depends on site of injury. Yes, absolutely depends on site of injury. Now the vagus nerve is the wandering nerve. It goes beyond the head and neck. So it has more functions than what's happening at the face and neck. Now, sensory motor. Now, basically, the vagus nerve gives us sensory input coming from the throat, but also organs. So you can say throat and organs, because I know it's hard to say, but organs like the heart, we're not consciously aware, but the heart, the lungs, the digestive tract. And motor is the same, swallowing and organs, because it's telling certain organs to release enzymes or gastric juices, for example. It tells airways to close up. It tells the heart to slow down. So I say organs because it's a wide range of functions, but I'll talk about those functions shortly. Vagus is hard. So you can see vagus involved in swallowing, and so is glossopharyngeal. So the two major cranial nerves involved in allowing you to swallow from your throat down your esophagus is going to be glossopharyngeal and vagus. Now the accessory nerve is motor, and it basically innervates the sternocleidomastoid muscle and the traps. Now we haven't done muscular system yet. When we do, you'll know sternocleidomastoid. You'll think it's a horrible name, and I often throw it in an exam somewhere because it's a horrible name. But basically, because it's the muscles of the neck and shoulders, well, I should say neck predominantly, it's for elevation, right? Elevation of the shoulders. So I'll just write shoulder elevation. And then the last one being glossopharyngeal is motor. And this is simply tongue movement. We've spoken about taste. We haven't spoken about how the tongue can move. All right, so quick recap of what we've done so far is we've gone through the 12 pairs of cranial nerves. We've named them, given you a mnemonic for that. We've spoken about whether they're sensory or motor or both. We've spoken about the function of the sensation or the motor portion of that nerve. Now let's talk about how you can test them clinically. So here's the clinical relevance. Question, how is the throat a sensory? What makes it sensory? Well, think about it. If you swallow particular foods, you feel it in your throat, right? So where does the receptors in your throat need to send it to your brain? So how does it do it? Well, it does it through the vagus nerve. The vagus nerve will pick up sensations. Now, glossopharyngeal sort of does it as well, but vagus nerve is the main one that picks up sensation of the throat and then brings it up to the brain. Why? Well, you need to know whether you're choking on something or not choking on something, or whether an object's too big, whether you need to chew it more, whether there's an issue, things like that. Does that make sense, Virginia? If not, please just let me know and I'll try and elaborate if I can. All right, let's do some clinical tests. All right, so olfactory. Olfactory is the sense of smell. So the way you can test your olfactory nerve is simply by smelling things. Now, you don't want to smell things that are pungent or toxic because that's damaging, right? Now, here's the thing. Gotcha. Cool. Thank you, Virginia. Okay. So when you do the olfactory nerve and you're testing it, it has to be florally or coffee type of smells, right? Can't be anything pungent or toxic because it may damage other nerves such as the trigeminal nerve. Think about it. Trigeminal nerve is sensation to the face. If something's toxic, you may stimulate the trigeminal nerve instead of the olfactory nerve, and you're going to get a false reading, and it's going to lead to issues. So you want nice floral smells, and you test the sense of smell. That one's pretty easy. Are all the eye nerves connected or separate from each other? Do they branch off of one? Oh, that's a great question, Georgia. Okay, so Georgia asked a question in the chat. Are all the eye nerves connected or separate from each other? Do they branch off of one, if that makes sense? All right. So all the nerves that innervate the eye, such as the optic, the oculomotor, the trochlear, and the abducens. Now, if we just focus on the motor ones, right? Oculomotor, trochlear, and abducens, they all come from distinct regions of the brain stem, all right? Now, think about this. I told you last week, anytime you want to consciously move, so I'm consciously moving my mouth, I'm moving my hands, I'm writing, I'm dancing, I'm singing, I'm doing all this type of stuff. Anytime you do that consciously, it must start at the cerebral cortex, and it must start specifically at the motor cortex. Now, I said the motor cortex is the frontal lobe. That's in the frontal lobe, right? So it starts there. Then it shoots down to the brainstem. Because it's motor, there's only 2 neurons. Comes down to the brainstem and then synapses with the lower motor neuron, and that goes out to the eye, for example, and tells it to move. Now, the thing is this, there's a conversation. So you've got an upper and lower motor neuron for each of these oculomotor, trochlear, and abducens. So they are separate, but there's a conversation that's had between all of them. So they all do come together to speak to one another, to synapse to one another. And that's why you can't just move one eye to the right while the other one stays straight ahead. Because they converse, they don't just converse with each other, they converse across the hemispheres so that both eyes move at the same time. Does that make sense, Georgia? If not, let me know. I can elaborate a little bit further for you. All right. We did our olfactory sense of smell test. optic vision. So like I said to you, this one was like the one where you stand there and you read those letters on the wall. All right. So that's giving you vision. Now, what it does is the sensation of vision is light coming in. So these are photons coming in, hitting your retina, so hitting the rods and cones, and then sending a signal to your brain for you to be aware of it, understanding. That's got to do with the optic nerve. The oculomotor nerve is the motor output. And so, for example, you've probably seen the test where it's called the pupillary reflex test, where you get a torch and you shine it in one eye and then back out and you watch the pupil constrict and dilate. So when light goes onto an eye, it doesn't want all that light coming in, so it constricts reflexively. In actual fact, if you shine, and you can, practice this with not a bright light on yourself, you can look into the mirror and you can put like your phone light across your eye and you can see your pupil constrict, but the other pupil will also constrict. Don't shine, please. Don't shine the light in your eye directly and don't leave it in your eye. This is all common sense stuff. But when you put the light across the pupil and back out, so you just go across and back out, not just the pupil that receives the light, but the other pupil will constrict as well. And this is important because there's a conversation had, like I just said, across the two eyes. So when someone has a stroke and one eye is affected and looks like the opposite way of the other, how come both eyes don't go funny? Great question. So this has to do with issues of pressure in the brain. So the question from Virginia was, sometimes people can have one pupil that's dilated and another one that's constricted. And this has to do with if there's a bleed on the brain like a stroke, pressure in particular area can put pressure on just one of the optic nerves. Because the optic nerves, right? So if you've got your eyeball, so you can see that the image that comes in goes to both sides, right? So whatever's coming in goes down that way, but also down that way. And the same for this one, it goes down that way and also down. So it crosses over, information crosses over. Sometimes you can have a stroke and a bleed, and it can put pressure on one of the cranial nerves, which means there's an issue with just one. And so only the reflexive response for one gets affected. All right. This depends on where the stroke is and what happens. Again, hopefully that makes sense. You'll be talking about that when you do pathophysiology next year. We'll be talking about strokes and we'll be going through the specifics of what happens. So again, I love these questions. Keep asking these questions, please. So optic vision coming in. Oculomotor is eye movement. So you can test oculomotor, you can test trochlea, and you can test abducens with a single test. All right, it's called the H test. Okay, thanks, cool. So the H test is like this, right? So you stand, get somebody to take your finger and you start in, let's just say the top right-hand corner of your vision, and you look at it and you move down and you follow that finger and you go back up, go down the middle, across, up and down. See how I drew a letter H? We'll start again. Up here, down, up, here, down, up. That H test is testing all three: oculomotor, trochlea, and abducens. All right. So that's one way to test three nerves in one. The other thing is that oculomotor isn't just moving the eye, but it constricts the pupil. So when you do that pupillary light test, do we see color through cranial nerves? That's a good question. Color is interpreted in the cortex of the brain. So we've got rods and cones. Rods and cones help us with understanding the intensity of light and the color of light. Right? They've all got sensory neurons embedded in them. They are basically sensory neurons, right? Rods and cones. And like I said, they give us that intensity of light and also the color. Depending on which one gets hit by which wavelength of photons. So you know that light coming from the sun is white. It's white light because it contains every wavelength of light. So some wavelengths will be blue. So Roy G. Biv, right? Roy G. Biv. These are the wavelengths. You've got red, orange, yellow, green, blue, indigo, violet. Then on this end, you've got ultraviolet, and then on this end, you've got higher wavelengths of light, all right? These are the ones that we see. Any lower, so we can't see ultraviolet because it's below the wavelength that we can see. And red, up above red is going to be infrared. So up here is infrared. We can't see in infrared. We can't see in ultraviolet. But this is the wavelengths that we can see. And basically, they're just wavelengths of photons coming in like this. Right? We can only see these ones. These are the ones that stimulate the rods and cones. And depending on which one we stimulate, they go to the back of the brain, up here, the occipital lobe, and this is where vision starts to make sense, and this is where color starts to come into play. Depending on which one we stimulate, depends on which color region it's stimulated in the occipital lobe, depending what color you see. Does that make sense? People who have issues like color blindness, for example, can have issues with their rods and cones, or you can have a central issue where the rods and cones are fine, the color is fine, but you can't interpret the color at the brain. We can talk about this another time. So, Lisa, does that make sense when it comes to where the color is interpreted? It's basically interpreted at the brain, but it's originally picked up at the rods and cones. All right. Now, what I was saying about the oculomotor is when we do the pupillary light reflex test, right? You put the light into the eye, move it away, and the pupils constrict. You're actually testing both, right? Because the light coming in is the optic nerve. It then speaks to the oculomotor nerve to say, oh, close that pupil, it's too bright. So when you do the pupillary light reflex test, you're actually testing both optic and oculomotor. So sense of smell, olfactory, pupillary light reflex test, both these two. Do the H test, we're doing oculomotor, trochlear, and abducens. Trigeminal, you can test the sensory component of trigeminal, like I said, by testing the 3 branches. Forehead, going down like this. That's the sensory. The motor for jaw, put pressure underneath your jaw and try and open it against pressure. If that motor component of the trigeminal nerve doesn't work properly, you won't be able to open your jaw against your own pressure. Usually you do this to somebody else. You don't test your own cranial nerves, really. All right. So we've done trigeminal, we did abducens. Facial is both sensory and motor. So the taste, well, that's the front 2/3. So tasting anything on the front 2/3 will give you the sensory component of the facial nerve. And motor is facial movement. So a lot of the time can you crinkle your forehead? If you can crinkle your forehead, you can smile and move your face, facial nerve's okay. Vestibulocochlear is hearing. So often you'll hear that thing where they looks like a Y and they hit it and it vibrates and you hear the sounds of vibration going closer and further away, or rubbing your fingers together, bring closer to your ear. And if the eye's closing, it's in front of me, it's close to my ear, behind me, close to my ear, further away, right? So this is vestibulocochlear. Glossopharyngeal is both sensory and motor. Sensory is taste, posterior. So taste, again, taste something in the back of your tongue, glossopharyngeal. And the motor for glossopharyngeal, remember, is salivation, swallowing. You don't really test the salivation. You can, but we usually do the swallowing. Now, here's the thing. Both vagus and glossopharyngeal are involved in swallowing. And an important phase of swallowing is the gag reflex, right? So if something goes too far in the back of the throat, somebody can gag. And this gagging is a reflexive response due to activation of both glossopharyngeal and vagus. So the gag response is a cranial nerve test for cranial nerve 9, glossopharyngeal, and cranial nerve 10, the vagus. For the accessory nerve, this one's easy. Put pressure on somebody's shoulders and get them to elevate it, like the jaw thing, right? Against resistance. Get their hands to go on your shoulders and you go resistance against that. So elevation, accessory nerve. And then the last one is hypoglossal. This is just tongue movement. So this is easy. Get somebody to poke their tongue out straight ahead. Now, sometimes if there's an issue with the hypoglossal nerve, tongue sticks out to the side like that, right? So there's heaps of different tests. So hopefully this makes sense. Any questions about any of these cranial nerve tests? I'll now tell you the type of stuff I'm going to talk about in your exam or questions in the exam, right? Types of questions you'll get in your end of trimester exam are things like, which cranial nerve allows for your sense of smell? And you'd say olfactory. You could say, if I were to rub across the forehead and then the cheek and then the chin or jaw of your face, which cranial nerve am I testing? And you could say the sensory branch of the trigeminal nerve. I could say getting a patient, or you could say something like, what test would you perform for the hypoglossal nerve? And the option may be stick out your tongue, right? So these are the types of tests. Or I could say, what number, so you do need to know the numbers. What number cranial nerve is the vagus nerve? And you'd say 10, right? So these are ways that I'll test you on your cranial nerves. Any questions on the cranial nerves before I move on and start applying some more clinical relevance? So we'll look at some stroke, for example, and then we can move on. What do you reckon? Any questions? Otherwise, I'll start rubbing this out. So let's talk about some clinically relevant stuff, such as stroke. Now, stroke is interesting because a stroke is basically when a blood vessel is no longer feeding a certain part of the brain. Stroke is, yep, thanks, cool. A stroke is when there's an issue with the blood. So it could be due to a bleed or it could be due to a blockage. Doesn't really matter. It's still a stroke. Now, remember this. I'm going to draw the brain back up again. So remember, this is anterior. So this is the front. This is posterior. This is the back. Remember, I said you got the central sulcus. And I said you got the bump in front, which is called the precentral gyrus, and you got the bump behind, which is called the postcentral gyrus. This part is the frontal lobe. This part is the parietal lobe. And I said you've got a particular cortex associated with at the front here, and you've got a cortex on the back here. Does anyone remember? I want somebody to answer me for this one. What cortex, so in the frontal lobe here, what does this control? What is this responsible for? This area here in the precentral gyrus. What does this do? Precentral gyrus is there for what? Can anyone answer me? And then I want you to answer me as well. What's the postcentral gyrus, that part of the cortex associated with? What do you think? I'll wait for the response. While we do that, I'll draw an arrow to it and an arrow to that one. And then when people give me the answer, we'll see. Motor. Thank you, Ali. Perfect. Frontal lobe, precentral gyrus. This is the motor cortex. And the parietal lobe is going to, Adam, legend, perfect, thank you, movement, absolutely. Parietal lobe and the postcentral gyrus, this is going to be sensation, so the sensory cortex. So this is just reiterating what we went through last week. Sensory for parietal, thank you, Adam, awesome. Pre is motor, post is sensory, rear, yes. Prima, yes. Georgia, yes, you guys are doing extremely well. Thank you, thank you, thank you. All right. If it's in the cortex, you're aware of it. I'll say it again. Don't ever forget this for the rest of your life. If it's in the cortex, you're aware of it. For sensation, if it goes to the cortex, you know that something has happened to you. It may be fine touch. It may be pressure. It may be pain. It may be temperature. It may be vibration. Doesn't matter. If it reaches the sensory cortex in the parietal lobe, you're aware. Now, when we look at motor, at the motor cortex, if it originates, if this motor signal originates at the motor cortex, it's conscious movement. So me moving my hand like this, it started here in the motor cortex, but my heart beating is not conscious. It doesn't begin in the motor cortex, all right? Me moving foodstuffs through my gastrointestinal tract is not conscious. It doesn't begin in the motor cortex. Is all this making sense? Please let me know. Does this make sense to you? Conscious movement begins here. What I want to now do is apply those 12 pairs of cranial nerves to see which ones are involved in conscious movement. So just quickly, we've got remember we've got optic, oculomotor. Sorry, God, I forgot my own cranial nerves. Olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. All right. Olfactory sense of smell. This is not a conscious thing. While we can bring things in, that's motor, right? But the sense of smell is not conscious. It does go to a cortex because we're aware of it. So the understanding of sense of smell is conscious. So olfactory will definitely hit the sensory cortex, right? So the question here is conscious? Which of these are going to go to the cortex is my question. Olfactory is a yes. Optic is a yes. Do we because we see things. If we're consciously aware that we've seen something, it's optic. Oculomotor, yeah, so we can consciously move the oculomotor, trochlear, and abducens. Trigeminal, sensory, yes. The motor movement of the jaw, yes. Facial, yes. Vestibulocochlear, yes. Glossopharyngeal, what's that going to be? Swallowing, so the conscious portion of swallowing, yes. Vagus, well, yes and no. Let's just say tick and cross there. Accessory, tick. Hypoglossal, tick. So all of these at some point are going to hit the conscious portions of our cortex. Or so if it's sensory, it's going to hit the sensory cortex, or if it's motor, it's going to originate here. Not all. So like I said to you with vagus, vagus nerve innervates the heart, airways, digestive tract. We don't consciously control that. So that never originates in the motor cortex. That originates in the brain stem. So if it doesn't originate in the motor cortex, it will originate in the brain stem. Brain stem is for what we call autonomic function, which I'm going to talk about very shortly. Now, some of these cranial nerves have autonomic function. While all of them basically have conscious function, some also have unconscious or autonomic function. Let's take a look. Which ones? All right. Oculomotor, pupil dilation and constriction, right? This is unconscious. We don't consciously control the pupil constriction and dilation. So oculomotor, we're going to highlight here. Trochlear, no. Trigeminal, no. Abducens, no. Well, when we look at facial, facial is salivation. We don't consciously control our ability to salivate. So the facial nerve is part of the autonomic nervous system as well. So we've got oculomotor, we've got facial, part of the autonomic nervous system. We've got, what else? Glossopharyngeal, I said, was also salivation. So that's going to be part of the autonomic nervous system. And then vagus. There are 4 cranial nerves associated with the autonomic nervous system. That's cranial nerve 3, that's cranial nerve 7, that's cranial nerve 9, and cranial nerve 10. These cranial nerves are part of the autonomic nervous system, which means you don't consciously control them. All right, the rest go here or here. So somebody has a stroke now. Let's say somebody has a stroke, they have a bleed on the brain, and this bleed happens in the motor cortex. Now, remember I said the motor cortex has a map of your body on it, right? So if we were to cut down the middle here and now just look at the motor cortex, right? Because the motor cortex is on both sides, you're going to find things like the throat, the mouth. That's a mouth, by the way. I know that's horrible. Let's draw that a bit better. The mouth, nose, eyes, neck, arms, hand, trunk, legs, and then on the other side, it's the same, right? In reverse. Hand, arm, trunk, eyes, nose, mouth, throat, right? So this is a map of the body on the motor cortex, right? So if somebody has a stroke, for example, in this area of the motor cortex that's dedicated to the hand or the arm, it means that the motor neuron that goes down won't be stimulated properly. And so often they can have paralysis of the arm, or the arm doesn't work properly. What if, for example, there's a stroke that happens here at the face, right? So you may get issues. So remember, there's no one nerve for the face, right? We know there's multiple. We've got the facial nerve for facial movement. But we've also got the oculomotor nerve, which allows for us to move our open and close our eyelids. We've got the trigeminal nerve, which gives a sensation to our face, right? So there's a number of nerves that may be affected. And so you can have drooping because there's a stroke in the area of the motor cortex associated with face movement, all right? There's also something called Bell's palsy, which is different to a stroke. So this is the thing. Somebody can wake up and they can have one side of their face drooping. Now, this is because of the lower motor neuron is affected on one side, right? So you can have a lower motor neuron affected on one side and it's drooping. You can't use that facial nerve on that side because there's a problem with that nerve. Usually it's a viral infection, something like that does it. But if somebody has a stroke, often, now it can be one side or the other, but often drooping of the face, it can be one side or the other, like I said, depending on which side of the brain that is affected. But one way that you can test is crinkling of the forehead, because the upper motor neuron that innervates it innervates both sides, right? There's no one side of the forehead really or the other. So you can test whether it's a stroke or Bell's palsy, for example, by crinkling of the forehead, if somebody has drooping of the face, to determine if it's upper or lower motor neuron affected. All right, that's just a quick run through of that. Now, I want to talk about these ones that are associated with the brainstem, autonomic function, because autonomic function is really important. It's going to be what we're going to talk about now for the rest of the tutorial. Autonomic function is part of the peripheral nervous system. All right, so what do you think about this? You got the nervous system, and you can divide the nervous system into the central nervous system and the peripheral nervous system. Now, the central nervous system is going to be, like I've said to you before, brain, brainstem, and spinal cord. Now, that's what we did last week, right? We're doing peripheral nervous system this week. In peripheral nervous system, there's some other things. Peripheral nervous system is basically everything else. Cranial nerves, spinal nerves, which I've said, right? Everything that shoots out and away and goes back into that. But you can break the peripheral nervous system up into a couple of things. You can break it up into what's called somatosensory or somatomotor. Now, somato means body. So somatosensory is sensation coming from the body. Somatomotor is conscious movement of the body, all right? But there's other divisions of the peripheral nervous system, which is autonomic. These are nerves that don't go to the somatosensory or somatomotor. These are neurons that go to motor aspects. Autonomic, you don't consciously control it. So I want you to remember autonomic is unconscious. So a couple of things. For the autonomic nervous system, autonomic nervous system is unconscious, motor output, and it innervates smooth muscle, cardiac muscle, and glands. Now let's think about this. It's unconscious, it's a motor output, so it's telling things to move, and the three things it tells it to move. Smooth muscle. Now, smooth muscle is muscle that lines hollow insides of stuff, right? So I've got a tube here. This tube could be my blood vessel. We know blood vessels can constrict and dilate, so they can go smaller, more narrow, or they can dilate and get bigger. Why? Because there's muscles in the walls of blood vessels that do this. You don't ever consciously control the diameter of your blood vessel, right? So that's smooth muscle. But smooth muscle is also found in your digestive tract, your esophagus, your urinary tract, your reproductive tract. All of these tubes are lined with smooth muscle that can dilate and constrict, All right. So we don't consciously control that. Autonomic nervous system does. Cardiac muscle is muscle of the heart. You don't tell your heart to beat once every couple of seconds. Your autonomic nervous system does. And this is probably part of that assignment. So we're going to be talking about that in a sec. Glands. So glands like salivation, for example, glands in your stomach or intestines that release enzymes to break things down. You don't consciously control that. So these are all autonomic. So any questions at the moment? Have a drink. All right. So we've done that. Next thing is you can break the autonomic nervous system up into two branches. The sympathetic and the parasympathetic. These are the two branches of the autonomic nervous system, and they're flips of the coin. The sympathetic nervous system is fight or flight. I'll tell you what that means in a sec. Parasympathetic is rest and digest. They're their nicknames. All right. Because the autonomic nervous system controls things you don't consciously control, like your heart, like your airways, like your digestive system, there's two divisions. Resting and digesting activates these unconscious parts of the body to make sure you stay alive when you're resting and digesting, when you're not doing anything. So that means when you're eating food, right, digesting, eating food, you want to salivate. So the parasympathetic nervous system tells your salivary glands to salivate. It also tells the enzymes in your stomach to be released. It tells the smooth muscle in your gastrointestinal tract to contract and move the food through. Tells your pupils to constrict because it doesn't need to let all this light in. It constricts it in. What happens when we have hyperstimulation of gastric juices? All right, I'll talk about that in one sec. So that's parasympathetic. Sympathetic is the opposite, not things that happen when you're relaxing, things that happen when you get stressed. So you're walking the dog at night through a park and all of a sudden somebody jumps out of the bushes at you. You get scared. Right? You get stressed. Now, you already know everyone's been scared before. What happens to your body when you get scared, right? Let's just talk about this quickly. When you get scared, you activate the sympathetic nervous system. So I want you to write down some stuff for me. I want you to write down in the chat for me some things that happen to your body when you get scared. What happens? So think about what happens to your pupils. How do you look differently? What happens to your heart? What happens to your airways? Do you breathe differently? Like, tell me what types of things happen. If you can, then I'll write these lists up because this is important. So we have heart rate increases. Perfect. Heart rate doesn't just increase, but the contractile force increases. What else happens? Yes, increased heartbeat, perfect. Elevated breathing, yes. So respiration increases. What else happens? If you look in the mirror, how do you look? You shake. Perfect, blood vessels constrict, so shake. Blood vessels constrict. Now, more specifically, your peripheral blood vessels constrict. Now, if your peripheral blood vessels constrict, how do you look in a mirror? What color are you? Do you go pale or do you go bright pink? Pupils dilate. Yes, absolutely. Pupil dilation. Beautiful. Adrenaline is produced. Absolutely is. That's why it's called an adrenaline rush. Anything else happening to you? You look pale. Thank you very much. Blood vessel constriction. So when your blood vessels of your skin constrict, it makes you look pale. I'll tell you why in a sec. Anything else? Facial expression. Absolutely. Facial expression is probably an autonomic response, which is probably trying to scare them or change the facial expression in order for there to be some sort of antagonistic response. Because fight or flight means you're either going to fight or you're going to run away, right? Fight or flight. So cold sweats, yes, cold sweats, absolutely. Sweating. sweating when you're not hot, right? All right, let's focus on these. So you're all entirely correct. Does a similar thing happen when panic anxiety attacks? Yeah. Exactly, Cody. So an anxiety attack or panic attack in part stimulates the sympathetic nervous system. It's an autonomic response that you can't control that makes you feel like you're in a situation of fear, right? It makes you feel stressed. So you can have increased heart rate. You can be pale. You can be jittery, right? You can increase respiration and sweating. Absolutely correct. Body can stiffen up. Exactly. So let's talk about these. The question is, why do these things happen, right? Because again, your sympathetic nervous system gets activated not to make you incapable, it's to make you act better in this situation of fear. So someone's coming at you with a knife. Is that what anxiety tablets do? Anxiety tablets to suppress the sympathetic nervous system? Some can. I'll talk about that in a sec, because there's some anti-anxiety medications which are called SNR, serotonin noradrenaline reuptake inhibitors, SNRIs, right? So these particular medications stop adrenaline being taken back up in the neuron, because adrenaline is driving this system, right? I'll talk about that a little bit more shortly. All right, so why does it happen? Someone's coming at you with a knife. Your heart rate increases. Your heart rate increases because it sees somebody with a knife. You need to stay alive. That's your body. This is homeostasis. It senses a change in the environment and you need to respond to stay alive. Homeostasis. Heart rate increases to deliver more blood to your muscles. Why? So you can fight or run. Same with contraction. The heart pumps harder as well to deliver more blood, because the blood contains oxygen and glucose, and that gives you energy to be able to use the muscles. Your respiration increases. The more you more specifically, your airways open up. Dilation of your bronchioles. So the smaller airways in your lungs, they open up. So more air can get in. More air, more oxygen, more energy at the muscles. You shake. You shake because all this adrenaline is going around the body, and what it can do is it tells the muscles to contract, relax, contract, relax, contract, relax. The blood vessels constrict peripherally. Now, the blood vessels in your skin constrict for two reasons. One, if it constricts, there's more blood being redirected to more important areas of your body, like your organs, but also your muscles. So again, you can fight and run away. That's why you go pale when you get scared, because your skin throws all its blood away to the muscles of the body. Your pupils dilate and open up. Why? The bigger they get, the more light that can come in. You can see your surroundings better. Adrenaline is produced. Now, this is the thing. You're probably thinking, didn't adrenaline cause these things? There's two things, adrenaline and noradrenaline. Adrenaline and noradrenaline. People get confused. If you're American, instead of saying adrenaline, you say epinephrine. Or you say norepinephrine. It's the same thing. We're in Australia, so we say adrenaline, not epinephrine. So please don't write epinephrine in an exam, because we don't use those terms. So noradrenaline is the neurotransmitter. This is released by the neurons. Adrenaline is a hormone released by the adrenal gland. Now, the adrenal gland sits on your kidneys. Ad meaning on, renal meaning kidney. It's the on-kidney gland. It releases adrenaline. I'm going to show you exactly how these two things interact to result in all this. And sweating, because the neurons associated with the fight or flight system can go to your sweat glands and tell them to sweat. How quickly can you become pale? Is it instant or over time? Instant. This whole system gets activated quickly because fight or flight must be quick. All right. So let's have a look at this. Let's compare sympathetic versus parasympathetic nervous systems, because it's important. And then we'll finish up after that. It's going to be a little bit longer tutorial than than usual. So I hope that's okay. If you've got any more questions, just pop them up. All right, so let's do this. Let's just draw up a brain quickly. Let's do midbrain, pons, medulla, and let's do spinal cord. All right. Brain, brainstem, spinal cord. Here's the thing. Question, could you please repeat noradrenaline? Yes, I will. I'll go through noradrenaline when I do this example. All right, first thing, let's do sympathetic nervous system first. Now, both sympathetic and parasympathetic nervous systems are 2 neuron changes. Why is it sometimes you freeze up when you're scared? Reason why you freeze up when you're scared has to do with a central nervous system issue. So it can be due to a basal. So there's complex motor pathways deep in the brain called the basal ganglia that allows for us to initiate movement and smooth movement out, and also the cerebellum and also the motor cortex. There's a constant conversation between those 3 areas before it even goes out to the body. When somebody gets scared, the release of neurotransmitters like adrenaline and dopamine can change the dynamics. And sometimes people can't initiate a motor movement because the conversation has been disrupted between these 3 areas because of the sensory input coming in. Hopefully that makes sense, Ria. It's a complex interaction, but basically those 3 areas, motor cortex, basal ganglia, cerebellum. All right, sympathetic nervous system is 2 neurons, right? And they always come out of the thoracic and lumbar region. Thoracic, lumbar. So sympathetic neurons, you know, they innervate the heart, innervate the lungs, innervate the pupils, innervate the blood vessels, right? All those things we just spoke about. The neurons always come out of either the thoracic or lumbar region. Now I'm going to draw up some examples. So comes here, goes out, synapses with another one, and then goes out. Now here's the thing. This may be, the second neuron is going to synapse with an organ, and it might be the heart, it might be the airways, it might be the eyes or pupils specifically, right? So this is the sympathetic nervous system. The parasympathetic nervous system, no, okay, let's just first focus on this. Because it comes out of either the thoracic or lumbar region, so there's a whole bunch that come out. I've just drawn up one example. Because it comes out of the thoracic or lumbar region, the sympathetic nervous system in textbooks is sometimes called the thoraco-lumbar system, right? Because the neurons come out of the thoracic or lumbar region. All right, a couple of points. If a neuron is leaving the central nervous system and then synapses with a second neuron, I told you last week that anytime you have a cell body of a neuron outside of the central nervous system, it's called a ganglion, right? So that means that this neuron here is called the preganglionic neuron. This neuron is before this ganglion, so it's called the preganglionic neuron. This neuron is called the postganglionic neuron. I need to say that because that's how we refer to them, right? And from now on, I'm going to refer to either the preganglionic or the postganglionic neuron. Any questions so far? No, not yet. Okay. When a neuron wants to speak to a second neuron, it needs to release a neurotransmitter. Now, the neurotransmitter released by this first neuron is called acetylcholine. Sometimes we write that as ACH. That's the neurotransmitter. Now, acetylcholine must bind to acetylcholine-specific receptors on the postganglionic neuron. So there's going to be receptors here specific to acetylcholine. Now, acetylcholine receptors come in 2 flavors, nicotinic and muscarinic. These ones are always nicotinic. What that means is the postganglionic neuron always contains nicotinic acetylcholine receptors. Let's recap quickly. The preganglionic neuron for the sympathetic nervous system releases acetylcholine. It binds to acetylcholine-specific receptors called nicotinic receptors on the postganglionic neuron, which then sends the action potential down further. Once we hit the end of this, what have we got here? So are there any differences between the pre and postganglionic neurons, or is it just a way of labeling? Yes, there is. So the neurotransmitters they release and the receptors they have are different. So once the action potential gets to the end of the postganglionic neuron, it needs to release neurotransmitters. These neurotransmitters must bind to very specific receptors on the target organs. This neurotransmitter is different to this one. Sympathetic nervous system is fight or flight. It's adrenaline. So this is noradrenaline. That's the neurotransmitter is noradrenaline. And it binds to adrenaline-specific receptors. Adrenaline-specific receptors are called adrenergic. And there's different kinds, which I'll tell you in a second. Let's recap. For the sympathetic nervous system, preganglionic, postganglionic neuron. Preganglionic releases acetylcholine and binds to nicotinic receptors. Propagates the action potential until it hits the end, where it releases noradrenaline and binds to the specific target organs and binds to adrenaline-specific receptors and has their function. So when adrenaline, or noradrenaline, I should say, binds to the heart, stimulates it, beats harder and faster. When it binds to the pupils, it relaxes it so the muscle opens up. When it goes to the airways, it relaxes it. So activation of the heart, but inhibition of the airways. So it relaxes and opens up. If you stimulate a muscle, it contracts. We don't want it to contract in the airways. We want it to open up so it relaxes. So some receptors result in activation. Some adrenergic receptors result in inhibition. Now let's look at parasympathetic, and then we can compare the two. Now the parasympathetic nervous system, the neurons always come out of either the cranial I should say, or sacral regions. Always come out of the cranial or sacral. Now think about this. We spoke about cranial before, cranial nerves. So the neurons of the parasympathetic nervous system coming out of the cranio or sacral region, in textbooks it's sometimes called the craniosacral system. Sympathetic is thoracolumbar because the neurons come out of either the thoracic or lumbar. Parasympathetic either comes out of the cranial, so brain or brainstem, or sacral. Now let's just draw it coming out of the cranial. So cranial nerve. It could be a cranial nerve that innervates the salivary glands, right? So it's a 2-neuron chain as well. One neuron and another neuron. Now, what does it innervate? Pretty much the same structures. So it can innervate the heart, it can innervate the eyes, but like I said before, it can innervate the salivary glands, right? So that's a tongue. That's a horrible drawing. I'm going to rub that out. That's a tongue salivating, and the airways as well. All right. So a couple of things. Similarities, 2-neuron chain. Now you may have noticed I've drawn the preganglionic, so that's a preganglionic neuron as well. That's a postganglionic neuron, same names. You can see a couple of differences. First of all, the preganglionic neuron of the sympathetic nervous system is shorter, and the postganglionic neuron is longer compared to the parasympathetic nervous system. Let's look at the neurotransmitters released. Preganglionic neuron, as a transmitter, will also release acetylcholine. So that's good. That's easy to remember. That's a similarity. Both sympathetic and parasympathetic nervous systems will release from their preganglionic neuron acetylcholine, which means it binds to acetylcholine receptors. And these are also nicotinic. So again, easy to remember. Everything's the same so far. But once we get to the end here, to release its neurotransmitter, it's not going to release noradrenaline because that's going to have sympathetic effects. It's acetylcholine again. So the parasympathetic nervous system releases acetylcholine at the pre and post ganglionic neuron. So these organs must have parasympathetic receptors. Now, acetylcholine receptors. That's nicotinic. The other type are muscarinic, and that's what these ones are. Muscarinic receptors. So if I asked you in an exam, when we look at the parasympathetic nervous system, what receptors do the organs that are activated by the parasympathetic nervous system have? They're going to be muscarinic. Or I may ask you a question, what neurotransmitter is released by the preganglionic neuron of the parasympathetic nervous system? Acetylcholine. What neurotransmitter is released by the postganglionic neuron of the sympathetic? Noradrenaline. Now, a couple of points before I finish. Are there any questions about this at the moment? Now, remember this. When the parasympathetic nervous system gets activated and hits these structures, it activates them in a way that they best function for resting and digesting. For the sympathetic nervous system, when it does this, it activates these structures to function best in fight or flight. So last thing I want to talk about, unless there's any other questions. Oh, yes. So question about noradrenaline and adrenaline, right? That's noradrenaline. What can happen for the sympathetic nervous system, amazingly, is that, let's just wipe this off for a sec so I can draw something up. One of the preganglionic neurons of the sympathetic nervous system goes straight out to the kidneys and innervates the adrenal gland. Right? Now, if it's a preganglionic neuron, what's it releasing? Acetylcholine. And it binds to acetylcholine specific receptors on the adrenal gland. But the adrenal gland, amazingly, this is a really important point, right? The adrenal gland will release adrenaline. Will release adrenaline. And we haven't done hormones yet. But adrenaline being a hormone means it goes into the bloodstream. Neurotransmitters just get released from a neuron, so they're localized. Neuron releases neurotransmitter and it has its effect right there. If anything's in the bloodstream, it goes to the whole body. And adrenaline will bind to adrenergic receptors pretty much in the same way that noradrenaline will. So when this gets activated, releasing adrenaline into the bloodstream, every organ is affected for the sympathetic nervous system. That's why when you have sympathetic effects, it's never just the heart rate increases. It's never just the airways open. It's never just the pupils dilate. It's all of them together. You always get for the sympathetic nervous system all of the functions acting at once, because as soon as the adrenal gland gets stimulated to release adrenaline in the body, the whole body gets affected. And that's slightly different to the parasympathetic, where it's very targeted to the organ. So you can just salivate, or you can just constrict your pupils, or you can just open up the airways. Constrict the airways, sorry. Hopefully that makes sense. All right, no questions at the moment. I want to focus on one more point, then I'll finish. So no questions about this, otherwise I'll wipe it off. Last point is the receptors. We need to go through the receptors, because clinically, that's really important. So pop up a question if you got one. All right. Now, when we look at, can you confirm the due date of quiz 3 before we finish? Like I said at the start of this tutorial, quiz 3 is due at the end of next week. Friday next week. Again, I emailed a study guide, an interactive study guide, and it says all this information. Go back through your emails, go onto the Learning at Griffith page. It says opens Monday this week, closes Friday next week. 2 weeks it's open. You'll do a good job. It's on all 3 nervous system topics. This is the last point I want to finish on. Adrenergic receptors. I just uploaded a video on this on the YouTube channel, so you can watch that, but this is important. All right. I said to you that, the heart, the eyes, like pupils, for example, the airways, what else? The blood vessels of the skin. They've all got these receptors on them that are specific for adrenaline or noradrenaline, right? Now, these receptors are what we're talking about here. Let's have a look. These receptors can be classified a couple of different ways. You can have alpha receptors and beta receptors. That's how we write them. But let's just do alpha and beta receptors. And there's 1 and 2 alpha receptors, and there's 1, 2, and 3 beta receptors. So there's 5 different types of receptors. This is how you remember it. Ignore beta 3 receptors. Simple. They're found on fat cells, and they really have no clinical effect that you need to be aware of. So there's just 4 you need to know. Write this: A1, B1, A2, B2. So write that up. Then do this. Box them up like that for me. Underneath, you can write stimulate. And here you can write inhibit. Then you can write this. Alpha 1 specifically is found on all smooth muscle, glands, and organs associated with the sympathetic nervous system. Beta 2 is the same. It's located on all smooth muscle, glands, and organs associated with the sympathetic nervous system. Alpha 2 is located on, I'll stand over here for you, presynaptic membranes, which may not mean much to you at the moment. And beta 1 is located at the heart and kidneys. So I'm just going to go through this again. Alpha 1 receptors you can find on all smooth muscle, glands, and organs associated with the sympathetic nervous system. Beta 2 is the same, all smooth muscle, glands, and organs. Alpha 2 is found on presynaptic membranes. So for example, there's one neuron, there's another neuron. The presynaptic, that's the synapse, right? So the presynaptic membrane must be that part there. Talk about that in a sec. And beta 1, these receptors are found in the heart and the kidneys. All right. If noradrenaline or adrenaline is released and binds to alpha 1 receptors or even beta 1 receptors, it stimulates the organ to do these things. So again, if adrenaline or noradrenaline binds to alpha 1 receptors, it will stimulate smooth muscle to constrict. It'll stimulate glands to release substances. It'll stimulate organs to do their function more. If noradrenaline or adrenaline binds to beta 1 receptors, it's going to stimulate the heart to contract faster, contract harder, and the kidneys. Look, don't worry about the kidneys. This is a more complex issue. Let's just do heart. Now, that's because these two are stimulatory. They stimulate their effects. Alpha 2 and beta 2, so the 2s, they have an inhibitory effect. So When adrenaline, this is probably going to be a concept that you haven't come across yet, but some neurotransmitters, when they bind to a receptor, they stop the organ from doing a function. So not all neurotransmitters will bind to something and activate it. Some will bind and inhibit it. In this case, if noradrenaline binds to alpha-2 receptors, what it does, because it's at the presynaptic terminal, it stops the sympathetic neuron from releasing its neurotransmitter, which means no action potential. So it's inhibiting the sympathetic effect. If noradrenaline binds to beta-2 receptors on smooth muscle glands and organs, it stops the smooth muscle from constricting. It stops the glands from releasing their substances, and it stops the organs from doing their activity. Now, what we can do is work backwards, right? I love doing this. The major effects that we just spoke about, the heart. If we're stimulating the heart through the sympathetic nervous system via adrenaline, what type of receptors is it going to have? Well, this one's easy because it's written right there. So the heart has beta-1 receptors. Perfect. The eyes, the pupil wants to dilate. So that's a relaxation of smooth muscle. So where's this? Beta-2 receptors. The eyes must have beta-2 receptors, the pupil specifically. What about the airways? We want the airways to open up and relax. So we're inhibiting the smooth muscle, right? If you activate muscle, it constricts. If you inhibit it, relax it, it dilates. So this must be beta-2 as well. What about blood vessels? Well, blood vessels must be, well, it depends on the blood vessel, right? So if the blood vessel is for the peripheral blood in the skin, we want to constrict it. So it's going to have alpha-1 receptors. If it's a blood vessel at the skeletal muscle, they're going to have alpha-2. Please comment, does this make sense? Because now I can talk to you about clinically relevant stuff to finish off, because there's going to be drugs that you've all probably heard about. Now, I want you to answer this question for me. Has everyone heard of a certain type of drug called a beta blocker? Yes or no? Has anyone heard of beta blockers? They're some of the most common drugs. Yes, I think. Anyone else? Has anyone else heard of a certain type of medication called a beta blocker? Really common. Beta blockers, strange. Yes, okay, cool. Heard of it, can't remember, that's cool. Common. They block the beta receptors. Now think about this, right? Beta blockers. More specifically, they're not just, the beta blockers that are currently available aren't just random beta blockers. They're specific. Often they're beta-1 blockers. I heard of it, but don't know what it did. Okay, cool. Beta blockers block beta-1. If you're blocking the receptors of beta-1, noradrenaline can't bind. The heart slows down. People who have hypertension, high blood pressure, they don't want their heart to go crazy. We want to slow it down. So they take beta blockers, right? That's one medication that's used for the heart, for example. However, think about this. If it's non-specific, so that's a beta-1 specific blocker, but there are beta blockers that are non-specific, which means it's going to block B2 as well. So think about this. What if you take a beta blocker and it doesn't just slow the heart rate down, which we want, or slow down the contraction, but it blocks noradrenaline from binding to the airways? Now, what does noradrenaline usually do when it binds to the airways? It binds to beta-2 receptors, and it inhibits the smooth muscle, so airways open up. We can get a big breath of air in. But if that's stopped, the opposite happens, and the airways constrict. It's harder to get air in. And if this individual is an asthmatic or has breathing issues already, it may be an issue for this person. This person may not be able to breathe, right? So non-specific beta blockers can have adverse effects for people, especially when it comes to respiration. Now, there's things that are beta agonists, for example, right? So some asthma inhalants are beta agonists. And what it does is binds to beta-2. So if you've got something that activates beta, so it's not a beta blocker. So beta blocker, you can have a beta blocker or beta agonist, which does, it agonizes, means it stimulates. you're going to have a beta agonist, which will stimulate these two. Now think about it. If you're an asthmatic, that's great because it means it stimulates beta 2 receptors, which means it relaxes smooth muscles and the airways open up. An asthmatic can get a big breath in, but it may also mean that the heart rate increases. So if any of you are asthmatics and you've taken maybe too much of your Ventolin, have you ever noticed that your heart rate increases? Maybe. If that's the case, it's because it's a non-specific agonist of beta. All right, so what ingredient is in it? Well, it's when we look, so it's going to be an agonist of a beta. So it's going to be some sort of chemical that's very similar in structure to noradrenaline. Okay, so I'm going to finish here because we're a little bit over time. Hopefully that was helpful. Hopefully we spoke about some clinically relevant stuff. Apart from that, I'll make this available on the Learning at Griffith page under the tutorial folder, and I'll upload it onto the Facebook page as well. So thanks everyone. Any final questions, pop them down now. Otherwise, I will speak to you all soon. I wish I could see you face to face, unfortunately, but thanks again. Thanks, everyone. Hi everybody, Dr. Mike here. So this is our second online tutorial for our online version for 1805 NRS now. We had the first one at 10 a.m. this morning. This is the second one at 2 p.m. We will be reiterating concepts and content that we went through at 10 a.m. But I'm also going to answer questions from the live chat. So if there's any specific topics or concepts that you'd like me to work through, please pop it on the chat. I can have a quick read and then we can get to it. So a bit of housekeeping to begin with. First thing we need to talk about is the fact that we no longer have a mid-trimester exam. We now have a written exam. So I've uploaded a tutorial for you to watch. I've uploaded the topics. So if your surname begins with A to M, your topic is the heart. If your surname begins with N to Z, your topic is the respiratory tract. And with the respiratory tract, you can choose anywhere along that respiratory tract. So it could be the trachea or the bronchi or the bronchioles or the lung tissue itself. It's entirely up to you. I've also put out the marking criteria for all that topics as well. And what I need you to do is go into the assessment tab on the Learning at Griffith page and review all the written assignment information that's there. Any questions, please send me an email. I'll be able to give you a hand. With these tutorials, what I want to do is figure out a way to best support you and provide you with information that helps supplement your learning. So obviously the fact it's not face-to-face means it's less dynamic. However, the fact that I can get your information here live and answer your questions will be brilliant. If there's any problem with my sound quality or the visual quality, please just let me know. What we're going to work through in today's tutorial will be last week's content, which is lecture 4, which is tissues and integumentary system, and this week's content, which is lecture 5, the skeletal system. The first thing I'd like to begin with is when we look at lecture 4, tissues and integumentary, we need to first focus on tissues. So when we look at tissues, a couple of things. We already know from the way we've built this course so far, we have atoms, we have elements and ions. They're the smallest things we basically work with, right? We have atoms that come together to form molecules. These molecules form together to form bigger structures, macromolecules, right? Proteins, fats, carbs, and so forth. These macromolecules come together to form organelles. These are small structures within a cell. So organelles come together to form a cell. And then cells come together to form a tissue, which is what we're talking about here. and then tissues come together to form an organ or organ system, and then organ systems come together to form an organism, you or I. All right. Now, when we look, so we've already built our way up to tissues now, and there's 4 different tissue types you must know. So these are the 4 different tissue types. You need to know connective tissue. You need to know epithelial tissue. You need to know nervous tissue. And you need to know muscle tissue. Now, what do these things do? So very quickly, what they do is connective tissue wraps and protects. Sometimes I say binds and protects. Epithelia lines hollow organs, but also forms barriers. Nervous tissue sends messages via neurons. And muscle tissue, well, what muscle tissue does is it does work. That's the term that we use. It does work, but it moves things, right? It moves our skeleton. It moves substances inside hollow tubes, like our gut, for example. But it also tells blood vessels to constrict and dilate, and it tells our muscle to contract to pump blood. Tells our heart to contract to pump blood. Now, these are the 4 different tissue types. Nervous and muscle, we're not going to focus on today or this week, because next week we're going through the nervous tissue, and then the subsequent weeks we're going through muscle tissue. So let's wipe these 2 off and let's focus on connective tissue and epithelial tissue. Now, there's heaps of different, let's first focus on connective. There's heaps of different types of connective tissue. What do you need to know? You need to know these particular points is that connective tissue is made up of 3 things. It's made up of cells, gels, and fibers. Now, this is what I focused on in the lecture on my YouTube video, so I'll just be very brief. There's different types of connective tissue, right? So, for example, bone is connective tissue, blood is connective tissue, lymph is connective tissue. There's something called connective tissue proper, and that's made up of dense connective tissue and loose connective tissue. And this can include things like adipose or fat. All these things are connective tissue, but they're pretty different from one another, right? So you've got bone, which is hard, and blood, which is a fluid. So compare bone to blood. Oh, another thing that's connective tissue is cartilage, right? Something we're going to talk about today. But bone and blood, both connective tissue, but very different. One's very solid, one's fluid. So what makes connective tissue? Well, it has to do with these cells, gels, and fibers. Now, the cells vary from one to another. So bone will have its own specific bone cells, which we'll talk about. Blood cells, lymph cells, and so forth. The gels is like a jelly. I like to think of the gels as a jelly. If you're making jelly at home, it's basically water with a bit more substance to it, okay? It's something that can be easily broken apart, but you can embed things in it. And the things that you can embed are the fibers, and there's 3 different types of fibers. There's collagen fibers, elastic fibers, and reticular fibers. Now, the cells vary. The gels are very similar between one another, and it's like a jelly. But then what makes something hard or fluid or whatever it may be, or squishy or whatever, is the fibers embedded in the gels. That's what's important. And so when we look at bone, you have a lot of collagen tissue, right? When you look at something like cartilage, you've got collagen tissue, but you've also got elastic tissue, because cartilage isn't as hard as bone, for example. So this is what happens. So think about some jelly that you put rubber bands in, or you put steel metal rods in. It changes the way it moves, its dynamics. This is what you need to know. All right. The next thing we need to talk about is that because of your assignment, as an example, right? Because of your assignment, you need to know about the 4 tissue types within the organs or structures that you're referring to. So if you have the heart, for example, you need to talk about the connective tissue that's at the heart. Is it areola or loose connective tissue? Is it dense connective tissue? Is it cartilage? Is it bone? What type of connective tissue is there? And why is it there? What is its function? We know connective tissue's overall function is to wrap things and protect things. So I assume it has something to do with that. So you just need to do your research. Same thing when it comes to the respiratory tract. All right. So that's connective tissue. When we look at epithelial tissue, let's see if there's any questions at the moment. In my past class, we went through all the layers of the dermis. I thought we didn't need to know that this year. Sorry, this is from last week's content. I'll talk about that in 1 second. Talk about that when we go through the integumentary system in a sec. When we look at epithelia, what you must remember is form equals function. All right, what does this mean? So epithelia can come in a number of different forms, right? So for example, epithelial cells can be squished like that. Epithelial cells can look like cubes. Epithelial cells can look like columns. And that's their actual name. This one is called squamous, meaning squished. Cuboidal, shaped like a cube. And columnar, shaped like a column. Easy. So that's their structure, right? As individual, what we call epithelial cells. But they can then be arranged in different ways. So for example, if you have a single layer, one layer of epithelial cells, it's called simple. If you have two or more layers, it's called stratified. So for example, squamous is squished, cuboidal shaped like a cube, columnar shaped like a column. Something to talk about first here. Why? Why are they like this? All right, think of why we have cells. We have cells because they're little cities. Inside these cities, we have factories and post offices and libraries and things that allow for the city to work. If it's squished, is there going to be much room inside to have all these organelles or intracellular compartments? The answer is no. Squamous cells don't do much because they don't have anything really inside to let them do anything. So they're not producing anything like a city. They're not producing anything, and they're probably not going to take something in to use. So why do we have squamous cells? Well, let's get back to that in a sec. The cuboidal cells, they're bigger. They have more intracellular compartments and components and organelles, so they do produce things. So cuboidal cells are likely going to release things from the inside and probably take things in from the outside. And the same thing happens with the columnar cells. They're likely going to release things that they've made and take things in to be used. Right. Now, when we look at the layers, let's just start with squamous, for example. If I had one layer of squamous cells, you would call this simple, because it's one layer, squamous. So this is called simple squamous. Easy. But that is just describing its form. But form equals function. So knowing that it's simple squamous should tell you what it does. I told you, it's not going to produce anything to be released. That's not happening. It's not going to take anything in because what's it going to do with it? There's no components inside to use anything. So simple squamous cells are there to let things pass through. So simple squamous, wherever you find areas that have simple squamous, it's there for things like diffusion. Simple squamous. The form tells you the function. It makes sense. It's not there to protect anything. You'll easily be able to break through a simple squamous barrier. It's not there to produce anything because it can't. Does that make sense? Hopefully that all makes sense. Now, let's talk about the other ones, for example. See if there's any questions so far. Do we need to know the in-depth information on cranial, vertebral column, thorax, and upper lower extremity bones? If you go onto the Learning at Griffith page, you will see that we have a bones list. All right. So if you go into the tutorial notes, there's something called a bones list. They're all the bones you need to know of the body that I will assess you on in an exam format. Okay. Bones of the body, the bones list. Access that. All right. Cuboidal. You can have a simple cuboidal layer, or you can have a simple columnar layer, for example. You can even have, let's wipe this off, you can even have, for example, let's move on from simple layers, let's look at stratified. What if we had many squamous layers like this. I want you to think about form equals function. Firstly, it's called stratified squamous. That's pretty easy. Hi everyone. Hi everybody, Dr. Mike here. In this video, we're going to take a look at the differences and similarities. Hi everybody, Dr. Mike here. In this video, we're going to take a quick look at the neuromuscular junction.